Yep, it's time for another Puscast, covering the first 2 weeks of December 2013 and the last podcast of this year. I'll be doing the next one over the January 3-4 weekend. So I'd like to take this opportunity to thank all my listeners. I've been doing this, I think, since 2006. So I am one of the old geezers of podcasting. I'd like to wish each and every one of you a generic, non-denominational seasonal greeting. The references, of course, are online and are at edgydoc.com. And when you think about it, wouldn't a perfect Christmas present be a glowing review of this podcast on iTunes? Otherwise, let's move on to the literature. Regular listeners and house staff who work with me know that one of the bees in my bonnet is inflammation and vascular complications. That infections leads to inflammation. Inflammation is prothrombotic. And virtually every infection that has been looked at has found an increased incidence of various cardiovascular events following the infection. This is most well described with influenza, but there are now 2 more articles out that show the same. The first is zoster. And this demonstrated that compared to people who don't get zoster, the risk for an acute coronary syndrome hazard ratio is about 1.15, and it remains greater than 1 even when adjusted for age, sex, and other comorbidities. This is not the first study to show that zoster is associated with an increase in vascular events. As I remember, the other one was an increased risk of stroke. The other study had a slightly different design intent. They looked at the effects of infection, both preceding the stroke and after the stroke, on outcome in young people who had a stroke, young being 15 to 49. Now, they found that if you had both a pre-stroke infection or a post-stroke infection, you had worser outcomes, i.e. a long, high-term mortality. But the interesting thing is that 10% of young people with a stroke had a preceding infection, and it was most commonly a URI. So this is more data. This suggests that infections lead to inflammation, lead to prothrombosis, lead to vascular events. If I get an acute infection, I am probably going to take aspirin a day thereafter. Probably should be taking it now, all things considered. But the future of post-infectious disease treatment, I bet in the future, is going to be some type of long-term antithrombotic therapy. There just isn't the data yet to support it. But I've made my prediction, and when it comes true, the James Randi Foundation owes me $1 million. We are heading into flu season. Yay. Evidently, they're predicting a bad flu season this year. I don't know. I heard this on the news, and the news always gets everything wrong. Everyone listening to this podcast, of course, is vaccinated. There are a couple of interesting things relating to flu and flu vaccination this year. A question that frequently comes up is giving vaccines to people with various and sundry immunodeficiencies. I wonder what the difference between various and sundry is. I should actually look that up. But this looked at the effect of various and sundry immunosuppressants in RA patients and whether or not it affected the outcomes of vaccination. And they found that it depends. Methotrexate was the most effective in decreasing the response to the pneumococcal and the influenza vaccine. Also, Rituxan had a similar effect, but anti-TNF therapy did not. So you can expect a patient on methotrexate or Rituxan to have less effect to pneumococcal and influenza vaccinations. This is what I love about epidemiology. Different studies can show different outcomes. So there's a study in vaccine that looked at the risk of hospitalization in patients who had the influenza vaccine. And they found in this population study of about 5,000 patients, the vaccination for influenza did not reduce the risk of subsequent hospitalization. But then the CDC uses a much bigger data set, but different methodologies. And I'll be damned if I'm smart enough to be able to tell you the difference in the two studies. But they found, quote, influenza vaccine resulted in 6.6 million fewer illnesses, 3.2 million fewer medically attended illnesses, 79,000 fewer hospitalizations. And this is with a presumed efficacy of the flu vaccine of around 50%. And most studies would indicate that getting the flu vaccine is about 50% efficacious. So depending on your methodologies and depending on how you interpret the data, you can find the influenza vaccine will decrease or not decrease hospitalizations. I think the bulk of data would suggest that it does. This interesting differences depending on your methodologies shows up again in varicella zoster. Now, there has been an increased incidence of zoster in the elderly, and it's been hypothesized that this is in part due to the vaccine. And subsequently, adults are not getting boosted by being exposed to children, and that's why we're seeing more zoster in the elderly. This study in the Annals of Internal Medicine suggests that this is not true, and that they found that the increase in zoster preceded the use of the zoster vaccine in children, and therefore it can't be blamed. And this is based on a data set much larger than the prior studies. They went back and looked at 2.8 million charts to determine when varicella zoster infections started going up in Medicare claims. It's amazing the things you can find out with data mining. I will admit I'm not entirely convinced because it seems reasonable that if you're not being constantly exposed to varicella zoster, i.e. chickenpox, that may be a factor in the increased incidence of zoster in the elderly. And some studies have suggested that zoster is occurring at a younger age, but all epidemiologic studies are open to bias and interpretation problems that make a definitive statement difficult. The other amazing thing about this study is it was published in the Annals of Internal Medicine, which, as best I can tell, I don't think I've talked about for years since they've had a quality or interesting article. One of the awful diseases of medicine is Stevens-Johnson syndrome. If you've never seen a case, count yourself lucky. But the severe cutaneous blistering disease of Stevens-Johnson is awful. There is, however, a microbiologic cause of mucocutaneous bullous reactions that looks just like Stevens-Johnson syndrome that was reported out of Taiwan. And it is a Coxsackie virus, specifically Coxsackie virus A6, which can mimic a Stevens-Johnson syndrome. They have 6 cases out of 21 with this particular Coxsackie virus that was the etiologic agent of a mimic of Stevens-Johnson. It's a bug that also causes, as you may remember, hand-foot-mouth disease, which has been a big problem in Southeast Asia over the last couple of years. It's sort of an advanced version of that, I would suppose. Someone mentioned in, I believe, a review of one of my books, The Pus Whisperer, available on Amazon.com, that I tend to repeat my, quote, humor, unquote. Well, I'm a infectious disease doctor, not a comedy writer, so I tend to be a little bit repetitive. You try doing this year after year and come up with new material. I've mentioned in the past that infectious diseases is a lot like birding. We have our life lists of diseases that we would like to see, although unlike birding, infectious diseases is actually interesting. It may be that I will finally get to see a case of measles. Measles has gone up 3-fold in the United States in the last year. Often in groups for religious or other reasons don't get their kids vaccinated. And these kids tend to cluster. So one measles into that little nidus of unvaccinated people can rapidly lead to the spread of measles. I may, before I retire, and that's getting closer and closer, actually get to see a case of measles. Maybe the only disease I want to see less would be smallpox. My dad also told me that I was in the original measles vaccine trials back when I was a kid. So I never had measles. I got to be in the vaccine trials. So I've been a guinea pig from the beginning. Good news, human breast milk inactivates hepatitis C, so that may not be an important way of spreading the virus from mother to son. Although this was not a study that looked at infectivity, but rather the ability of milk to support or decrease viral viability. I do not know about your institution, but we obsess about every surgical wound infection in our hospital and do these deep dives and spend an inordinate amount of time trying to figure out if we could do anything differently to prevent infections. We don't find anything because we do everything pretty good. But there was an interesting study, and you guys know my affinity for vitamin D deficiency and its risk for infection. But they looked at the risk of a surgical wound infection in patients who were vitamin D deficient and found that those who had a level less than 30 had an increased risk of post-operative hospital-acquired infections. This was a group that had a Roux-en-Y gastric bypass. So it was a very specific surgery. But those who had higher levels of vitamin D had fewer infections. I live in the Great Pacific Northwest where sunshine is often rare, and it makes me wonder if all our patients should be on vitamin D supplementation before and after surgical procedures. Kind of related and not of worries here in the Great Pacific Northwest is the fact that voriconazole can cause a photosensitivity reaction. A study out of France shows that it will potentially lead to skin cancer. First, they get chronic photosensitivity. Then they got actinokeratosis. And then finally, in the third year, they ended up with squamous cell carcinoma. So the suggestion should be that people on long-term voriconazole who get photosensitivity reaction should have consideration of discontinuation of the voriconazole or live in a place with no sunshine, like Portland. Bartonella causes, amongst other things, cat scratch disease. And it's long been noted that patients can get cat scratch disease without being scratched by their cat. Could it be, say, tick-borne? This study was out of Nigeria, and they looked for the presence of various and sundry, again with that phrase, Bartonella both in rodents and their ectoparasites. And they found that 26% of rodents, predominantly rats, and 28% of their ectoparasites, with a variety of names that I can neither pronunciate or spell, were found to have Bartonella species such as Bartonella elizabethae, Bartonella tribocorum, and Bartonella grammii. So if Bartonella can be found in the rats and it can be found in their parasites, there's no reason it won't be found eventually and subsequently in humans. What occurs in our animals occurs in us. I have seen exactly one case of mumps. Well, two. There was the case I saw in a middle-aged truck driver, and they have a Super 8 film of me, quite adorable, with the mumps. They also have a Super 8 film of me, again, quite adorable, with chickenpox. But not all that glitters is gold, and not all swollen parotid glands are due to mumps virus. This study looked at the incidence of other viruses found in patients with acute parotitis and found a hodgepodge, not various and sundry this time, but a hodgepodge of organisms isolated in patients with acute parotitis. They found EBV, HHV6B, human parainfluenza virus, and human Boca virus in patients with acute parotitis. And more importantly, they didn't find mumps as a cause. So there is a lot more that causes unilateral or bilateral parotitis than mumps in human beings. Now, of course, association is not causality, and one would need to do more studies to see if these viruses were actually causative of parotitis, EBV isolation always being a problematic virus. But there's more to parotitis than mumps. You know, I'm an ID doc. I like cultures, including blood cultures before antibiotics. This somewhat paranoid article, I say paranoid because, at least on the PubMeds, it says twice, not once, that this article is protected by copyright, all rights reserved. This group is very, very possessive of their data. But they looked at 800 patients with complicated urinary tract infections and found that 30% of them had positive blood cultures. But interestingly, 7% of patients had bacteremia by something other than what was in their urine. So it is important to get blood cultures in patients with fevers who are being admitted to the hospital, because even if you suspect urosepsis, there is about a 7% chance, give or take, that they'll have another organism in the blood that may or may not determine a different evaluation and a different therapeutic intervention. And don't forget that with this article, all rights are reserved and it is protected by copyright. Here is the problem. If you have an MSSA bacteremia and your initial therapy is vancomycin, and you wait to change to the beta-lactam until you get your susceptibilities back, i.e. change to nafcillin or cefazolin, you have worse outcomes than if you have a Staph aureus bacteremia and you get a beta-lactam up front. The studies, to best of my knowledge, have not looked at the combination of, say, vancomycin and cefepime or vancomycin and ceftriaxone, since many patients get a third-generation cephalosporin in addition to the vancomycin. The question is, if you're worried about staph bacteremia, should you start with vancomycin and a beta-lactam whilst you're awaiting for the results of the cultures? They say that in this nice review of the topic, maybe we should, that there is no definitive clinical trials out there, but most of the data is indicative that you'd be better off with staph in the blood, treating initially with vancomycin and nafcillin, and then backing off. I do just that when I have CNS infections, meningitis, epidural abscesses, brain abscesses where I'm worried about staph. I give nafcillin and vancomycin up front and then drop whichever one isn't needed. I don't tend to do that with bacteremia. And as I say, the study does not address the issue about patients who are on other beta-lactams, such as third generations, which are supposed to have some staphylococcal therapy like cefepime. A couple other things of note. One of the problems you have with community-acquired pneumonia or pneumonia in general is people get started on vancomycin. Can you stop it if you do not isolate MRSA, even if you're worried about MRSA? This study addressed the issue with the predictive value of a swab for MRSA with PCR and found that a negative PCR can be used to guide the cessation of vancomycin in patients with pneumonia and has good sensitivity and specificity for lower tract disease. The other issue of note, and I can't emphasize this enough, is if you get newly colonized with MRSA, your rate for an infection goes up dramatically in the next year, especially if you have a Pianton-Valentine leukocidin-producing strain of MRSA. One of the reasons that we don't want to give MRSA to our patients in the hospital, even if they don't get into trouble now, this is one of multiple studies to show that if you get newly colonized with MRSA, your chance of getting invasive disease is markedly increased. New colonization of MRSA is a bad thing. And finally, this is probably a well-titled article. Minocycline, often forgotten, but preferred to TMP sulfa or doxy for the treatment of community-acquired methicillin-resistant Staph aureus skin and soft tissue infections. A long title. But they basically said in this article that if you're going to use a drug orally for the treatment of MRSA, that minocycline is reliable when compared to doxy or TMP sulfa. And I actually never think of minocycline, so it's forgotten by me as well as by others. I also, as I think about it, need to look up the cost of minocycline, since doxycycline has gone from inexpensive to moderately expensive because the producers, as best I can tell, are price gouging. Shocked that a pharmaceutical company would charge an arm and a leg for a newly popular drug. But it's gone from like $10 a prescription to like $60 a prescription, depending on where you get it, for no good reason that I can ascertain. I have been reported a couple of times to administration in my career. The first time was, I think, my first year in practice. I had a guy who was hit on the head and found unconscious, and he had a big bleed between his scalp and his cranium. that subsequently got infested with maggots that kept the wound clean. But he looked like he had his head in a bowl of rice. When I saw my residents down the hall, and remember this is my first year in practice and I was quite enthusiastic, I shouted down the hall to them, "Guys, come down here. See this head full of maggots?" This was 23 years ago or so. And somebody reported me for shouting that down the hall, and they were right to do so. That being said, maggots have long been used as a therapy for debriding wounds. There's actually a randomized controlled trial that was observer blinded that looked at the difference between using a larva and hydrogel in the debridement of wounds, and found that 76.9% of patients in the larva arm had a good debridement, compared with only 34% in the hydrogel arm. And it looked like larvae were superior to other care in the debridement of a wound. You can buy these over the internet, by the way. I do not know, however, how many of the patients in the larva wing got an antiemetic so they didn't puke every time they saw worms in their wound. I don't doubt it's a great therapy, but it's up there with stool transplants with a big ew factor. I have been doing this already, but at least it's nice to know that it's supported by the literature. The study looked at the issue of immunoglobulin deficiencies in patients admitted with strep pneumoniae or Haemophilus influenza in their bloodstream. As a rule, when I get a patient with strep pneumo in their blood, I always do an SPEP looking for myeloma or Waldenstrom's, as well as immunoglobulin levels. This would suggest that I'm doing the right thing, and that patients who had invasive disease with those two organisms, 37.8% had an immunoglobulin anomaly, including immunoglobulin G deficiencies, immunoglobulin A deficiencies, and immunoglobulin M deficiencies. And 8 had monoclonal paraproteins. So besides an HIV, which is usually done in patients with strep pneumo or Haemophilus influenza in their blood, always check them out for an immunoglobulin deficiency or a paraproteinemia. And for what it's worth, I bet I diagnose about one a year that way. There is some interesting theoretical information to suggest that cooking food was one of the things that allowed us to develop our big brains. Eating raw food is harder to digest and is not efficient, and by sort of pre-digesting our food with cooking, we allowed better access to calories, and this led to bigger brains. I won't say that people who eat raw foods as a consequence have smaller brains, but certain raw foods are at risk. There's a nice review in Emerging Infectious Diseases that looks at the issue of drinking raw milk and found outbreaks of both E. coli 0157 and Campylobacter associated with drinking raw milk. As I have noted before, the udder of a cow is, gravitationally speaking, just below the cow's butt, and that is not a clean area. And gravity would tend to bring the poo into the milk. Thank goodness for pasteurization. And evidently in the Midwest, there's a tradition of eating raw ground beef sandwiches. And they are evidently called cannibal sandwiches. I did not know that. This is a Wisconsin deal, and I did my residency in Minnesota. But this too has been associated with outbreaks in the holiday season of E. coli with hemolytic uremic syndrome. I'm sure they ate their raw meat sandwich with a nice glass of raw milk. And so that brings this last podcast of 2013 to a close. The next one will be released sometime in January 2014. I wish everybody a generic and non-denominational seasonal greeting. Don't forget that the references and links to my growing multimedia empire is available at EdgyDoc, where you can find links to my podcasts and my books and my apps, and oh my goodness, do I keep busy. Otherwise, as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you despite the hassles of Epic. Thank you. In dictation, goodbye.